So good afternoon, everyone, and thank you for joining our webinar today related to the Riverstone Recovery Center. I'm Krista Ross, CEO of the Fredericton Chamber, and I would like to introduce our presenter today, Dr. Sara Davidson. She is the Medical Director of the Riverstone Recovery Center. She's a family physician at the Fredericton Downtown Community Health Center, and she's a faculty member at Dalhousie Medicine, New Brunswick, and Memorial University. Her experience working with the city's vulnerable and unhoused populations prepared her for that position at FDCHC that serves the downtown population, including those without housing. 2 years after beginning an innovative addiction medicine practice at the FDCHC, Dr. Davidson led a team to successfully secure funding from Health Canada's Substance Use and Addictions Program to create an addiction medicine center for opiate and stimulant use disorders and to run a 5-year pilot project developing best practices for injectable opiate agonist therapy. She is, as many of you know, also a tireless advocate for solutions to the housing crisis we are experiencing here in Fredericton. So without any further ado, I'm going to turn the microphone to Dr. Sara Davidson to make her presentation.
Thanks very much, Krista. And I thank everyone for taking time over your lunch hour to join and to listen to my presentation. So before I begin, I just want to do a land acknowledgement. Oops, going the wrong way. There we go. So Riverstone Recovery Center and many of the places you're working, no doubt, are located on the traditional unceded territory of the Wolastoqiyik and the Mi'kmaq and the Passamaquoddy. And the important part in this treaty understanding is the land wasn't surrendered. It was really just to try to find ways of working in an ongoing relationship between groups of people. And that is in the essence of what I think all of us are trying to do today. So it's a nice way to start. And again, appreciating all of you being here. So what is Riverstone Recovery Center? So I really appreciate this opportunity because I certainly want to make sure that everyone has the most kind of relevant and informed information about what we're doing. We did open under the cover of COVID in July of 2020 is how we framed it. And so in that case, we didn't really start with a big splash about who we were. We just wanted to hit the ground running, and a lot more concerns in healthcare were out there than what we were doing. So, but it's now time. We've had a lot of experience and we've been growing. And so it's time for us to really share what we do. So the things I'd like to tell you during this webinar, what Riverstone is not, because there are some misconceptions out there, but why our treatments are needed so badly in Fredericton and all across New Brunswick, how we've responded to the toxic drug supply, which is coming in, is already here in this province and in the Maritimes, results from our first 2 years worth of our trial here and our studies that we're doing ongoing with our participants, some of the exciting plans we have regarding participant employment that we're working towards, and my ideas for other ways, as Krista said, around housing advocacy. So some ideas I'd like to share and certainly get your feedback on. So what is Riverstone? So we are a medical clinic, and the most important thing I'd like to share, we are a very caring community of healthcare professionals. We have case managers and we have peer support workers, and we really believe that everyone has the right to healthcare, housing, dignity, and purpose. But we're also, as I said, a medical clinic, and it's really important to understand that we are not a safe injection site, first of all, and a lot of people think that's kind of the same thing compared to what we do, but we prescribe medication for people who treat their opiate and stimulant use disorders. A safe injection site is a spot where people bring drugs that they have gotten illicitly or illegally, or maybe they've been shared by someone else or what have you, but they've brought them to that site to use in an environment that is safe, it's warm, it's protected from the elements, which are very important parts of being able to keep someone as safe as possible. And often there's healthcare staff or peer support workers around that make sure that if someone does overdose and die, that they're revived and that they're brought back as best they can with Narcan, which is an injectable reverse agent for opiates. But a safe injection site still keeps people in a criminalized position. So the difference between what we're doing at Riverstone is people are prescribed the medications that they inject on site here. And I'll get into a lot more detail later on. But the really key piece there is that this is a healthcare clinic providing for a healthcare issue. And I want to reframe substance use disorder, especially intravenous drug use, as a healthcare issue, not a criminal issue. So what is the need for treatment? So the illicit drug supply is definitely toxic and unpredictable. And we all think of the West Coast when we think of fentanyl and that sort of thing, but there is fentanyl here. We've had fentanyl deaths already, overdose deaths in this province. As there's my point, fentanyl is in New Brunswick. New Brunswick has the second highest rate of intravenous drug use in Canada. So again, everyone thinks BC, but if we look at per capita, how many people inject drugs, New Brunswick is second after British Columbia. And that's a stat that really surprises a lot of people. We don't have nearly the same population numbers. So it's not, the numbers aren't as high as they would be in BC or Ontario or Quebec. But in terms of how many people, it's roughly 1 in 100 people inject drugs in this province. So it is worth trying to identify who those folks are and provide healthcare for them. About a quarter of people over age 15 will have some type of substance use disorder in their lifetime. So the more we can destigmatize substance use disorder of all kinds, the more anybody can access better mental health and physical health care. And since we've opened in July 2020, we've had about 800 people that have inquired about care here. So the need is there, and that's without even really, that's more word on the street and people word of mouthing rather than it being a broad campaign. We've had 400 people that have become participants during that 2-year period in Fredericton. So we have 288 currently. So there is some coming and going, and that's not unheard of within substance use treatment. And we have 160 people that have already joined in our St. John clinic since July of since this summer. And not all of those people are necessarily, these 400 people and the 288 currently, this is for the whole gamut of addiction medicine that we do here. And not all of it is our injection program. But again, we'll get into more details later on. So what's the cost of intravenous drug use harms that are related to that to New Brunswick? So if we look at, there's all the information is here right in front of you, but over the last 6 years, there's been 443 overdose deaths in New Brunswick. And for a really small population, that's quite a high number. And just over half of that has been from opiates. Very often it's from a combination, we call that polypharmacy, more than one drug in the person's system. But then if we look at the rate, the 2018, there were 110, 2019, 127. So, and then it went to 125, stabilized, but 2021, during the real heart of the pandemic, it went up to 175. And in 2022, this went to 194 just through September. So it's not even finished all the statistics. So it's just showing you that it's a growing concern and that we do need to be addressing this. In terms of the costs financially to New Brunswick, I mean, the life costs and the cost of family and community losing people is huge. But if we actually just look at the costs in particular, hospitalization alone for harms related to substance use disorder is about $13 million a year. So a lot of people might think that, oh, this is just affecting a certain number of people and this is a really small problem, but it's actually huge. And the cost of the system for something which typically is treated more as a criminal issue, and rarely are people accessing the kind of healthcare that they need because of that stigma. It ends up costing us so much money. So I don't mean to make people about money, but really when we're looking at system change and the need for it, there's not only an ethical reason to be treating people with compassion and with understanding it as a health issue, it's also going to help our bottom line and our really, really overstressed healthcare system. So there are other costs as well. Like that literally is just hospital beds. That's not looking at all the other health related costs. So we could probably add a zero to that number, to be honest, at times, given all the other things, the healthcare costs, criminal justice, and incarceration, social assistance, homelessness, lost productivity. And a really important note is that alcohol and tobacco costs our province incredibly higher amounts per capita. So although we're looking at opiates and stimulant use disorder today, it's putting that in the bigger context that there are other substance use issues which are legal, which cost untold amounts higher. So, excuse me, whenever we decided that we wanted to try to figure out what to do to help with this crisis in the province, we applied to Health Canada's SUAP. So that's a substance use and addiction program that's run under Health Canada. And it's a research body to look at what can we do better across the country. So as you can see here, the application that we looked to create Riverstone called for wanting to have efficacy of programs providing prescription grade opiates as alternatives to illegal street drugs. And that by doing that in ways that reduce mortality, decrease crime, and improve connections for housing and social support. So it's a big ask, actually. Many other medications for other healthcare issues don't necessarily have to include that whole wraparound approach. But the nice thing about our approach at Riverstone is we already have that holistic view of what health is for people. So then if we look at our story here, prior to applying for the Health Canada money, I had already been working for 2 years, as Krista mentioned, doing addiction medicine at the downtown clinic. And I was doing it in a drop-in setting. I would sit for 2 hours twice a week in our community room and just say, walk in, walk in, walk in, like, come, start on treatment. Like, as soon as someone's ready is when they should be offered treatment. Waiting lists are not appropriate for people that when they're ready to make such a significant change. So with that grew and grew and grew. And I think that was part of why we were successful applying, was the innovative approaches that we were already trying to do to really be rapid access for people. So in 2019, Health Canada said, we need to find ways to address the toxic drug supply. And so with the team that I already had going, we decided, let's get together, we'll pull all the best resources that we can in terms of looking at research that's already been done and what type of treatments that we could provide. And then we applied, and in September 2019, that's when we did the proposal that was sent in. And in February of 2020, that's when we were selected. And at the time, we were one of 5 clinics in Canada that was selected for a 5-year pilot. So there were 2 in BC, 2 in Ontario, and 1 in Fredericton. So we're incredibly proud of that, actually. And I think in many ways, it's a huge accomplishment to have a very small maritime city go up against the big guns in the bigger provinces. And I believe it was just because of the kind of the grit and the passion and the rapid access and our holistic approach that we were able to do that. So July 2020, that's when the intakes began. And in October of 2020, that's when our doors officially opened for the injection part of the program. And at that time, we were the first one in Eastern Canada. There's another IOT program that's going to be opening in Dartmouth. Plus we have our other one in St. John now as well. So speaking about opiate use disorder, we have about 20% of our participants in the program are being treated for stimulant use. When you hear stimulants, that means things like crystal methamphetamine or crystal meth, cocaine, speed, that sort of thing. But the vast majority of the 288 people in the program are on treatment for opiates. And we'd have 3 types of ways that we treat people with opiate use disorder. So that would be the daily oral medications. That's things you've probably heard of, like Suboxone or methadone. Cadian is an additional one, which is a long-acting morphine that they take once a day. And really, that's filling the receptors in their body that they normally would have illicit drugs filling. And so it keeps them out of withdrawal. It keeps them much more stable. The other option is monthly injections. There's something called Sublocade. It's relatively new, and it's just injected into the belly fat. And it's a dissolvable version. So once a month, people can come in and get that injected. And that has saved a lot of people a lot of hassle, because going to the pharmacy every day can be very frustrating. Or the third option is where we have up to 3 times a day where they can inject prescribed hydromorphone, which is a type of opiate, in a liquid format. And then they can get one of the long-acting ones for overnight that they take by mouth. And that just keeps people out of withdrawal overnight when they're sleeping, and then they come during the day and they get their injection therapy as well. And all of it is covered. And that's part of how we're moving from a criminal model into a healthcare model. So it's a prescription. So if we look at IOT in particular, that's what we're going to focus on now. And the most of this talk is really to focus on that part of the program, just because people don't know about it as much. So well-researched, cost-effective treatment for people that haven't otherwise been successful on oral therapies. So if we look at those things like Suboxone and methadone, for about, if you had 100 people, 85 people might do relatively well on an oral therapy that they go once a day to the pharmacy. Over time, they can work towards getting super stable, and then they can actually take those home maybe a week at a time worth of their medication. But there's about 15% of people, 15 to 20 roughly, with mild to moderate, in this case, severe opiate use disorder, that they won't be successful. Those medications will not be an appropriate treatment because they've tried. Very often people come to our IOT program and they have been on some methadone multiple times. They've tried and they've tried and they've tried. And there's just something about the chronic condition that is related to mental health issues and related to substance use disorder. These are not things that are like quick to abstinence, which means just stopping all drug use. Like, that is actually nowhere in the evidence is that the most suitable version for people that have an opiate use disorder is to try for abstinence. They're not successful and they'll relapse. That's just what all the evidence out there around the world backs up. So people have often tried oral therapies again and again. But again, Health Canada came out and they said the risk of harm that people are at who do continue, who go back to using intravenous drug use or injecting their medications will lead to things like overdoses and deaths, like we've seen. It could lead to overdoses that lead to then traumatic brain injuries, which will reduce their ability to cope and to function very well. They could be, if they're having to share needles, because there's so much illicit drug use that's still, because it's been criminalized. If one person has hepatitis C and they share a needle or they share any of the paraphernalia used, they often can share that hepatitis C with not needing to, but that's what ends up happening. We don't have a lot of HIV that's shared intravenously in New Brunswick, but certainly in other parts of Canada, that's a huge part is HIV. Hepatitis C, thankfully, is curable for the vast majority, but HIV, as we know, is manageable as a chronic condition now, but it's still not curable. There's also things of bloodborne infections, osteomyelitis, discitis, endocarditis. Those are the things that keep that $13 million worth of hospital stays as being so expensive, or usually those infections that are related to it. And someone who has endocarditis will be, and that's basically bacteria grows on the heart valves because it gets gets injected into the skin unintentionally, and then it grows, it circulates and lands on a heart valve, and it starts to replicate and multiply itself. And then that can lead to stroke, that can lead to needing a heart valve replacement. It leads to right-sided heart failure, just terrible, terrible outcomes for people, often who are in their early 20s. So you have people who become as if they have very advanced congestive heart failure that someone in their 70s or 80s might have. So it really cuts their legs out from under them for being able to work on anything to make their lives better when they've got, heart failure as well. So, but people that have infections like that often stay in hospital beds for about 12 weeks at a time. So they get stable very quickly, and then they end up having to stay just because they need their antibiotics intravenously 3 times a day in order to cure those significant conditions. And that, just bringing that piece in, because if we think of the way that we're using our hospitals, if we're using it to treat infections, which could be prevented by providing healthcare in the first place, we would save 12 weeks. Someone could get multiple knee replacements, multiple hip replacements, if we can keep people out of hospital. Okay, so the other wraparound services that we look at here, we're also providing, as I said earlier, that holistic approach. So we have case managers, we have wellness and empowerment programming, which is kind of workshops for people. We have peer workers, so people with lived and living experience that work on staff as well, because they know what it's like, so they can bring that wisdom and that expertise. We do rapid testing and treatment for people with hepatitis C. So we have found, right now, I think we have 21 people that are being treated for hep C, that the province through public health, they've been on their radar for many years, but they've never been able to track them down to treat them. So we've got 20 of them being treated right now. So it's a great way to access care and take care of a whole bunch of other stuff at the same time. And obviously the advocacy for housing really does need to be specifically for people who experience concurrent disorders. That means mental health as well as substance use disorder together. They're concurrent with each other. So a lot of the housing that we have out there in the community, unfortunately, is not set up in a way that tolerates people that are using substances. And I don't mean people that are partying like crazy and trashing the joint. That's not what I mean by using substances, just people who, as part of maintaining a physical health, to stay out of withdrawal, to not be as sick as possible, recognizing this is a chronic condition that you can't snap your fingers and say you can stop using drugs, because if they could, they would have. Trust me, they would have. No one wants to get to where they've lost their housing and all of their social supports because of a mental health issue. So recognizing that they're not going to be able to suddenly snap their fingers and become abstinent, we need to provide housing that has the right supports in place and has the expertise in the staffing and in the design of it and the running of it to provide support for people who still use drugs. I call this the spaghetti diagram, recognizing what recovery can look like for many people. There's this idea that, people should just be able to stop using drugs, but the reality is very different. And people's goals for themselves need to be individualized and people need to be met where they're at. So now I'd like to share some of the outcomes. So I've explained all the good reasons why we should do care like this, but what is that actually turning into? So we have a project coordinator who is interviewing people regularly just to do surveys, just to see what are outcomes. So if we look at, this is for people that have been in our program at least 6 months. So again, we've been running for 2 years. So 90% of the participants say that they've had positive changes because of being in the IOT program. And right now we have roughly, are we at 68? Or we're at 61, sorry. Well, we were at 58, sorry. We bumped up to 61 people, sorry. So we have 61 people that we're talking about here, roughly. A couple are new, so they wouldn't have been included in these numbers, but it's still quite a chunk of people. So 90% have positive changes just because of being in the IO program. So 71% improvements in mental health. You can see the stats here, almost 70% in physical health, almost 60% less conflict in their lives, 42% more time to pursue goals, more time to pursue other things like employment, like housing, like working with their families, again, reconnecting. Almost 40% improvements in personal relationship, and a third of them improvements in housing. And I would say if we had more appropriate housing, that number would be way higher, but nonetheless, it's part of our jam up. And all of this, I must say, is just because they're in a program. Mental health outcomes like that from a medication would be unheard of. You would never see that kind of improvement from any other treatment. It's just because they're in a space which is making them not criminalized anymore and making it into a healthcare issue for the vast majority. And you can see these are just some of the words that some of the people say quite literally. So I'll let you skim over these, but essentially we hear again, and the IO literally saved my life was not said by one person. That's been said multiple times from people that are in the program. It's getting rid of the worst thing that someone's experiencing in their lives, the need to stay out of withdrawal every day. Every waking moment spent directed at trying to stay out of the sickest, most flu-like feeling you have. Some of you might be having a viral infection right now. It's the right time of year. I know lots of people are a bit under the weather, but imagine the worst fever, flu, diarrhea, just sweating, chills, rigors, and that you're living in a bank machine with that. What in the world are you going to do? You're not going to say, today's the day I'm going to stop using drugs. You're going to say, what am I going to do to stay out of this horrible feeling? Because as soon as you can get the opiates and you can inject them or intake them in whatever way people typically do, that withdrawal will end. You'll go back to feeling back to normal. So that's the driver. It's not to say that people want to party and get high. It's literally to just get out of that feeling of incredible sickness. So now if we look at our outcomes in terms of housing stability, because that's another exciting thing. Now our project coordinator is still teasing through some of this data. It's a little bit early that we've discovered this one because we've been around long enough now to really have a good look at it. So there might be a little bit of wiggling around the 3-month people, in terms of this number. But essentially what this shows is that people at 24 months of the program, 2 years of the program, 89% of them are now housed. And those that are at 3 months, 20% are housed. I mean, it's like, it continues. I mean, there's a bit of a wiggle right in the middle of the 12 to 18 months where they sort of jog. But if we look at getting stable, getting treated not as a criminal, being treated instead as someone with a healthcare issue, being met in a healthcare setting, has led to people, and this is not because we've suddenly found amazing housing for people. As you all know, we're in a crisis, but still just because they're getting healthcare, that 90%. And at the start, 84% of our people have experienced homelessness. So this is coming from a huge population of people that were not housed and now are. So if nothing else, that really is eliminating a lot of the costs to our system in general with not having housing. This important one probably for businesses now, we definitely want to highlight this one. Very busy slide, but you can have copies of this if you'd like. We're just looking at the reducing of criminal behavior. So people that are in the IO program, if we look at in terms of, and we survey when people come, like we ask them about, what ways did you acquire your drugs ahead of time? We want to understand the whole picture. So how many people had to steal nuisance crimes in order to sell stuff, in order to then buy drugs and then to use them, versus those who were selling. And there's a combination often for some people. So at 3 months, 44% of people said they were no longer stealing. But at 12 months, 83% said they were no longer stealing. And those that 17% left over, they were stealing much less. I mean, that wasn't characterized in terms of numbers. But if we look at reductions of crime, we don't need more jails. We do not need more jails to reduce drug-related crime. We need treatment. We need appropriate treatment that meets people where they're at. We don't need the demand for abstinence to reduce drug-related crime. What we need is appropriate treatment. So again, I just really want to highlight that. These are showing the statistics of how we're reducing crime just by treating people. They're still injecting. They're still injecting multiple times per day, but they're doing it in a healthcare environment. And if we look at people that were selling drugs beforehand, 56% were selling drugs at 3 months, but 73% had gone. 56% were no longer selling drugs. Sorry, my apologies there. But 73%, so 3/4 at 1 year were no longer selling any kind of drugs. And the remainder quarter, they were selling much less. So there still are needs, like if someone's living outside and they don't have no access to food on a regular basis because they're having to go live way out far in the woods for being moved along and they can't always get to the kitchen, they're still going to need to eat something. They still might be stealing as part of that. So there's lots of reasons why people might still be. It's just really important, again, to highlight that this is not because we've incarcerated anybody. This is not because we've built more jails. This is not because we've come up with fancy housing. This is not because of anything other than meeting people where they're at. I know I'm beating a dead horse, but I just feel like these are such important points to take home and how we need to shift our thinking about substance use disorder and making it to a healthcare issue. So now I'm going to shift to the things that I hope will be of interest and pique some of your imaginations as well, and see if you even want to have further conversations later about this. We have a sister organization, the Works Housing and Social Inclusion Incorporated, and it's just in fledgling time frame. But we've got a worker, his name is Tony Kelly, who's quickly developing what some of the infrastructure for what it could look like. It's the non-medical stuff of how we can help people go further. So the first part is he's developed a 5-level employment readiness program, and we're hoping to work with organizations like Pedal and other organizations such as maybe members of the chamber too, to sort of build this so we're not just doing something in isolation. But the first start is to help people who maybe if they've been living outside a long time, they haven't worked for a while, how do we help them build up the confidence again? So the first level is what we call piecework. That's where people maybe come in for an hour. We've got we have a mural that we needed repaired in one of our rooms. And so one guy is going to be coming in tomorrow. He's a drywaller. So he's going to do some of the drywall stuff. He's going to work for an hour, and then we're going to give him money at the end of that hour, just pay him for his time. That's called piecework. And that's just getting this idea that you come up, you show up, you do a job, you go. He feels some self-esteem because he's actually done a job to help a clinic that he really likes, and he's getting paid for it. And we're really appreciating him. The next level, though, are short contracts for entry-level work. So we put out a call for people if they wanted to become cleaners here at Riverstone Recovery Center, at the pharmacy out front, and at the space that we have in the back where the Works is setting up. And we had about 27 people apply out of our program for 5 spots, 5 part-time little spots. So people that are living outside, people who use drugs, people who have complicated mental health issues want to work. That was just a huge, and at the time we weren't at 61 people. I think we were still in the mid-50s. So it was almost half of the people on our program wanted to work cleaning. So again, that's shifting that narrative that people don't want to work. They actually desperately want to work. They want to be part of something. They just feel scared, intimidated, and they recognize that they may not be able to do a 9 to 5. So that's the second part. They can show up for a part of the day, do their job, and they can get paid, and they can have that position for 3 months, and then we reassess. So we have some excellent people that are now doing cleaning, and they're feeling really excited. They're looking a lot better. I spoke with one yesterday, and she has stopped using all crystal meth on top of the opiates that she's using in this program as part of her healthcare. She's like, I just feel so good all the time. I don't even have to use anything else. And that's because she's cleaning. So then the next tiers we haven't gotten to yet because we're still building this, but that's where people would take on more of a managerial role and eventually supervising part of the program and then becoming a director. So this is what we're working at to try to build so that people who use drugs in the community can actually be engaged in meaningful work that they feel proud of. And we've even spoken with different businesses so far, just starting to put out some feelers where the Works would be the employer, but that we could be the Works could be contracted out to do sort of jobs around outside, whether we're raking leaves or whether we're helping with some painting or, doing that sort of thing. So very excited to be building that into our program now. The last bit I'll talk about is just what can we do around housing. And I know all of you know how bad things are for a lot of people regarding housing, but again, we don't have any housing dedicated for people who are struggling with concurrent disorders. And now we have 100+ people that are living outside this winter. And so it just keeps getting worse every year. So the province owns 2 healthcare facilities that I've identified, and I've spoken with a number of people, including people in the high executive level of Horizon Health who are really interested in these ideas. So this is the call to action that the provincial health plan identified that it wanted to be able to do. So it's a health system, citizen-focused, accessible, accountable, inclusive. So this is where I did this pitch. I had Minister Fitch here the other day talking about him with it. And talking with him about it, sorry. So one is, that's the downtown clinic where I work as a family physician. It's a prime real estate location. It's right downtown. We do have City Motel and the Oak Center now, and we have 12 neighbors across the river, amazing developments in housing for people. But as you know, especially the right downtown folks and businesses know, people are still drawn to the downtown core, that we're never going to change that. I live right downtown because I love downtown. And right now, unfortunately, it's being left up to a lot of the businesses to bear the brunt of our broken healthcare and social care system. So I'm not unsympathetic to how hard it is on businesses when you can have all of the people who no longer have any informal or formal places to go and be. And that it's just really scary and stressful for everybody, the people that are outside and the staff that are at the businesses seeing it. So for me, building something downtown is important. And it's really hard to identify any specific areas, but building above an existing health clinic that could provide wraparound supports. University of New Brunswick is a living lab for their students because they want to be an experiential learning program and make it cutting edge that way. So this is one of the pitches that I'm making to Horizon Health. They're in the midst of looking at the engineering piece. Is this possible even? but we already have a successful Horizon Health Jewel, and there's a lot of interest in that already. So just wanted to put that on your radar as a. And the other one, which this one is, been working at this for about 5 years now, at the Victoria Health Center, is it lots of people who don't want anything in their backyard say, why don't you just do stuff down there? And I agree with them. I say, why not? So working again, trying to get the province to, Horizon Health would love to have more there. And mostly because they could look at expanding some of the primary care needs that we need. And I don't mean just for this homeless population, but creating an integrated community center where you could actually have a whole bunch of people receiving more care, more primary care access, have an urgent care center, mental health ER, so that we can offload what's happening at the DEC hospital and bring things back into the community. And that's what they say that they're wanting to do in healthcare. There's a Healthy Seniors Aging in Place program at the downtown clinic. It could be expanded, keeping people out of nursing home, or just keeping them at home longer. And then we could actually, on the 5 acres that's there, little chunks could be built, small units could be built. We could actually add to the housing stock in a setting that already has some of the wraparound supports there. And then have the works, have the economic and social inclusion hub where people can work on job readiness skills, programming supports, and that kind of thing. Horizon Health's already there, and they're very interested in this as well. It's just looking at feasibility, but I did want to put this on everyone's radar. And this is just the mental health action plan again. So it's all the stuff we've already kind of talked about, but it's just, these are the things that the province has said that it wants to do. So to me, it does tick a lot of these boxes. And I guess for me, so how can we work together to address these shared challenges? We'll have a bit of time for conversation now. I'm happy to hear your questions or thoughts or feedback. But what I would like to really pitch, and potentially, one thought is, if you're interested in hearing more about the works, we'll be doing a lot more discussion about that over time. But Tony Kelly is someone that I can help you link up to if you think, hey, you know what, I might have a little job here or there around my business. And the more that the participants in our program feel like they're connecting with businesses in a positive way rather than in a negative way, they'll actually get a bit more skin in the game necessarily in both sides. Each other will get to know each other, and that communication and understanding is going to heal a lot more than just continuing to accept the status quo. And right now, unfortunately, I feel like the lack of focus on providing specific housing for folks with concurrent disorders is a bit of a downloading on the province onto the backs of the community, onto the people that are living outside, as well as to the businesses having to bear the brunt. I would strongly encourage, if you're open to it, to have a collective letter together that's sent to the Premier to say, we actually think you should be housing people, because he, unfortunately, is a bit of the barrier for some of these projects to get moving forward. He has a stronger belief that abstinence would be a better approach, that people should just stop using drugs and then they could be housed. But the reality around the world for up 30, 40 years worth of research says that that's not actually ever going to happen. So we're in a bit of a philosophical conversation, and it's not an evidence-based one. So I'd like to bring the evidence forward and say, you guys shouldn't have to, as business communities, be bearing the brunt. The people living outside shouldn't have to be either. And we see the benefit outcomes whenever we meet people where they're at and treat them with dignity. So thank you very much for listening, and I'll see what Krista wants to do now.
Thank you very much, Dr. Davidson. That was very informative, and some startling statistics, in particular, the second highest IV drug use in the country being right here in New Brunswick. So that's a very startling statistic. So I have a ton of questions that are rolling in through the chat. People are texting me. So with about 20 minutes left, what I'm going to suggest is that we answer them, as in brief answers, so that we can get to as many questions as possible. The first question that I received was, businesses have expressed concerns with your clients gathering near the center for treatment and then displaying behavior that discourage customers from coming to their operations or even downtown. What do you do about this, and how is this issue being addressed?
Yeah, it's a great question. I guess first part is not every one of them are actually members at Riverstone. So there's no informal places for people to go. So COVID really just unmasked how vulnerably people had any social spaces to be. And getting moved along happens everywhere. So it is a challenge. I recognize that. Right now I've tried to work towards opening a center where people could go. And that would be my ultimate goal, is to say, people actually deserve to be downtown. They are members of our society. They are members of our community. But yeah, they need somewhere to go where they can hang out and use the bathroom. I mean, it's just pretty common sense. And so it's talking with the city, talking with the province, trying to advocate for that, and ideally creating a spot for people to be able to go is the longer term vision. But in terms of what we do now, I mean, right now, I know that Alex Schulten at Victory has been getting his security, and we're trying to reinforce that too, that it's, you can be here 15 minutes before your dose and you can be here 15 minutes after, and then you need to leave the area. So the people that are actually participants, that's kind of the status quo of what we're doing. But the other people who just have nowhere else to be, those are often the folks that you're seeing, and they're not in our program. I don't mean to stigmatize them, say not our problem, but it's just they're not ones that we can have that rule over. But at the same time, they're ones that I hear what you're saying. I want our downtown to be a beautiful, vibrant place. And so we need to create a spot. There's potentially a warming daytime spot that's going to be opening. I don't want to let a cat out of the bag because we're waiting for a big amount of money to see if we can actually have that happen. But the money that we'll save in the long run by creating spaces that are appropriate are definitely needed. So I would encourage your advocacy. So we're trying our best, but recognizing it's a no-win situation currently.
So the next question is, with regards to the treatment itself, do the clients that use these treatments, are they on them long-term, or does it ultimately get people off of drugs?
That's a great question. It's a very common one. So in an ideal world, people might not need any medication for high blood pressure, diabetes, or anything. And that, I think, is every patient's wish, is to not have to take medications. If someone were on if someone was on insulin, for instance, for diabetes, and it got to the point where they needed a long acting and they needed to have with each meal, which is very similar to iode, actually a long acting and 3 doses. If they had food security, if they didn't have any chronic pain, they could exercise all the time, if they could work at a job that they really liked and their mental health was in perfect shape and they had great family support, maybe 5% of them could get off insulin. But most of the time, they're people who don't have food security, eat a lot of carbohydrates because they're at the food bank. They have a lot of chronic pain from injuries or whatever other issues, so they can't exercise. They don't have the financial stability to be able to do the things to take care of themselves to the degree where they can stop their medication. And I give that example because now we shifted over to the same boat. You're right in that the aspiration might be to get off all medication, but we don't make that a demand because it's not realistic. And studies show most people will relapse if they're forced to go off a medication, even for benevolent ideas that, oh, this would be better for you to not be on this. They'll often relapse. And so if we look pragmatically at the situation, it's not necessarily the goal. In European studies on iode, which is again the injectable program here, iode, it's taken about 3 years, and then people do stabilize, and then they're actually like, well, you know what, I think maybe I'm kind of ready to try an oral therapy again. So we have had one person who has successfully gone to an oral therapy now out of our cohort over the 2 years, and he was working the whole time. He's working now. It just became too much of a pain to come 3 times a day. Some of the folks who are looking at it are saying, I feel like I'm kind of ready, but until I'm living somewhere, it's just too hard to imagine. So it's a goal, but again, with all those other psychosocial issues not in place, it's not really approachable for most people. And the goal is not to get off drugs because this is a treatment. So it's to treat until you're able to shift something enough. I could talk a long time about that.
So another question that has come in, Dr. Davidson, is that your program sounds like it's very successful. So why do you think issues of addictions and some of the associated negative behaviors seem to be increasing in Fredericton?
I think the main reason, it's a great question. The main reason, I reflected on the first out of the cold shelter, at Bishop House, that was 4 years ago. We had 30 people living outside then. Now we have 130 people living outside. So it's not so much that we're necessarily having more people becoming addicted and more people acting out. It's just we have a group of people in some cases that have been living outside for 4 years now. And that the mental health, how hard that is on your head and how hard it is on your body to live outside. Or to live precariously, bopping in and out of shelter beds, that sort of thing, is incredibly destabilizing. So, and the other thing is the housing that is being created for people is not for people with concurrent disorders. So people that don't have concurrent disorders might be more likely to get housed. So we're really self-selecting for the people that have the greatest challenge, the greatest mental health issues. So we're kind of creating the worst case scenario for people in that we're not providing what they need and we're also not housing them. And now it's 4 years of this, if not even longer. Plus with all the issues around having almost a 0% vacancy rate, just lots of people can't get appropriate housing. There's lots of precarious housing out there. So our whole social system is a bit broken, looking at private developers to be able to take care of the problem. It's never going to happen. So I think what's happening, and COVID made everybody a lot more anxious. So it's a few confounding external things that have come in at the same time. I wish we could have cured everybody of addiction here. It's just not realistic, but it's becoming more known. It's becoming more addressed. But COVID really got rid of all the informal places that people could hang out and stay. And so it flushed out all the social issues to become much more visible. So I also think it's just, you're seeing it a lot more. It was always there.
Another question that has come in, you mentioned some of the businesses downtown are providing their own security, but do you have any security hired to help move along those folks that aren't your clients?
Yeah, we have security that work all the hours that we're open.
Okay, that was a quick answer.
I think I'll try.
You mentioned Dr. Davidson, a downtown location. Is there a specific location? There was Clinic 554 has been talked of, a space for recovery and housing. Is that still on the table? Talk to us about that.
Well, yeah, we do own Clinic 554, but right now, just with the amount of cost for like the inflation that's taken building supplies out of over like crazy, we're not current. I mean, I can't afford to build the type of housing that I would want to build there. I also would rather not be there, to be honest, for this type of housing. I would rather be somewhere that's more suitable, which would be Victoria Health Center and also downtown here at the downtown clinic, and perhaps in small pockets everywhere. So yeah, again, there's no real updates around 554. It's just at the moment waiting for things to settle down a little bit in terms of costs to build and to come up with. But my strategy again I'd rather be where everyone else would also like us to be.
So if the Victoria Health Center is the potential community hub, what is the obstacle, or what obstacles are in place? What is it that you would need to move forward on that plan?
I think a really strong political will from the premier would be the key thing. You know, I've spoken with Minister Fitch. I've spoken in the past with Minister Shepherd, you know, in their different roles that they kind of flip-flopped a little bit. I've spoken with Minister Green when she was in DTI. In the head of that, I'm hopefully going to be meeting with Minister Carr at some point, because he's now the one in charge of the facilities, just to really advocate. Like, there's a lot of people that think, oh, it sounds like a really good idea. It sounds like a no-brainer. And Horizon's like super excited to have anywhere they could be expanding. So I don't think it's a lack of finances. I don't think it's a lack of wanting or recognizing that there's problems. So part of it is in the Victoria Health Center now, there are various provincial agencies that get very little, they pay very little rent. And so the thought is, well, that's good for the province. But there's studies, I don't have a slide on this in here, but there's studies that for every person who's outside, chronically living outside, the downstream costs in terms of healthcare, incarceration, in police interactions, et cetera, is about $130,000 per year per person. So if we have 100 people that are outside, you know, add 2 zeros to 130,000, we get into giant amount, like $13 million a year is what it's costing. And it's not actually housing anybody. So the investment, we need to really take a bigger picture look and say, the premier, to be honest, that is probably the biggest block. If he said, yes, this is a good idea, this should happen, it would happen. So now maybe there's hiccups. The building is a little old, it's a bit rambly at VHC, but we've had John LaRue went through with David Kuhn, and he said, this is certainly a building we're saving. It's worth working with. It's not a tear down, it's not in horrible shape. And I'm used to making something from nothing. So I think that we could use some grit and determination. And speaking of labor shortages, for a lot of the peeps that are in our program have lots of history working in the construction trade. So we actually would like to start our own renovation company and build a lot of stuff ourselves. So there's a lot of potential. We just need the leadership from the highest level to say this really matters. And I think a lot would happen. So letters to the premier to say, stop downloading social issues to the city to deal with, to the businesses to bear the brunt of. Start showing some leadership and vision that we need to actually make changes, especially when we have a huge surplus. And there's also, you know, there was 400 million federal money waiting to be matched. I think it's down to 180 million now from the federal government, just sitting, waiting to be said, hey, what do you want to do with infrastructure? We could tap into that money. We've got a surplus, we've got the Fed saying match it, and then we could actually do a lot. So it's really a leadership, I think, at this point.
So when you start your renovation company, let's make sure that your company joins the Fredericton Chamber of Commerce.
Sure, I'd love
I'll,
that.
I'll just throw that out there.
Great idea.
Another question that has been added to the chat is that this person says they've chatted with some of our homeless folks and they choose to live in tents. They don't want to be housed in shelters. So what can be done to help them?
Yeah, it's a great question. And I think I'm going to nuance that a little bit. Some people say, therefore, they want to live outside. It's not that they want to live outside. They just know they can't be successful in the current offerings. So no one wants to live outside. I've never met anybody, even though I've talked to who don't want to go into the shelters. Some of the barriers, and I don't mean to throw shelters under the bus by any stretch. They play a big role, but the role has fringes, right? It has edges. And this is the territory that we're in, are on the edges. So if you have a partner that you're with, very often when you can't go in together in a shelter, if you have any possessions of any significant amount, and I know we see people with shopping carts that have a real hoarding mental health issue, and that's not what I'm talking about. That's people need support in that case for that. But I just mean general stuff that you have that you've acquired. You can't often bring it in with you, so you have to leave it outside. I mean, the risk of it just getting taken, stolen, moved along, thrown out by the city and the police is very high. If you have any animals, you can't bring them in with you. And I guess if you are still using substances, very often you won't succeed. You might last a day or two and then you're kicked out again. And I don't mean really high on meth, wailing around, freaking out. Like people that become psychotic on crystal methamphetamine never mean for that to happen. Most people are using it as a survival medication because it can keep you from feeling hunger, because it's a stimulant. It makes you not feel hungry when you're hungry. It makes you not feel cold when you're freezing. It makes you stay awake and alert when you're at risk of freezing to death. And it keeps you, a lot of people just walk around all night long because they don't feel safe to sleep outside. So it keeps you the ability to stay up and walk around so that you don't sleep and you're not at risk for physical harm or freezing or what have you. And it also, the saddest part is it makes you feel like your life's okay. So that's why people use meth. There's no way we're going to get rid of meth use in our city by telling people stop using meth. What we need to do is alleviate all of those pain points in people's lives by housing them, feeding them, giving them appropriate supports, giving them spaces that they feel that they belong. Then they'll stop using meth. It's a backward way, like to think they got to stop using it to get housed. It's like, well, they got to get housed to stop using it. So we're really in a bit of a jam. So I guess I completely forgot the original question, but that felt like an important thing to get to.
Yes, and I think that you answered the question. It was basically, why do people want
Oh
to?
yes, why do they?
Yeah.
It's because what's available they aren't going to succeed at.
So another question that arises from that, I guess, is how do you work with other stakeholder groups like the shelters, and do you have a good relationship with other groups that are trying to help people as well?
We work at it. There's very philosophical differences sometimes, so there is friction. I won't lie. I don't think I'd lie about anything, to be honest, but I won't hide that. Because there's different approaches. Some of the shelters work on more of the continuum and we work more on a housing first model. So just philosophically, that's a different idea around housing. I won't get into deep dives of that, but I think with Marcel Lebrun at 12 Neighbors, I think we have an excellent working relationship. The outreach workers for the shelter and for the Oak Center, like the men's shelter in Grace House and the Oak Center up at City Motel, they all have outreach teams and we have outreach teams. And there's been this really lovely synergy that's happened this past year. That's really been very intentional. And even with the nursing students that go out from downtown clinic, they on that front line level are working really collaboratively, and it's really great because there's no more of this overlapping and kind of infighting. And in terms of at the leadership level, I don't really feel that there's a lot of vision that's shared, unfortunately. I've tried to offer in-services something like this at the different facilities to explain what we do and how they can tap into our help, and people haven't wanted that. I keep trying to keep doors open, but I guess that's just, I can't really control what other people choose and what they want. But on the front line, the collaboration is exceptional, and that is where it really matters the most, not so much at the kind of high up level. So there you go.
Speaking of the front lines, you mentioned a number. And somebody has quoted it here, 194 New Brunswick overdoses. So I don't know if that was the exact number because I didn't catch that, but this person is inquiring how many of those overdoses took place here in our area.
I don't know if we would have that. And I guess, The other really interesting part to add to that, that number is just, they basically find that number through either the number of times that naloxone has been administered by someone who's in EMS,
Mhm,
or the coroner, like coroner reports for lethal overdoses.
mhm.
But I'm sure it's a lot higher, to be honest. I'm sure it's higher because there's people like actually whenever I in the groups that we have, because a lot of our folks that are living outside in tents, fentanyl is quite cheap. And unfortunately, if someone is really distressed and they've been moved really far away from anywhere, and not everyone living outside's in our program, I must say, we're still trying to build ourselves up and grow, grow and grow and grow and get even more people. So there's lots of people that aren't in our program. I wish they all were, but they're not. But of the people that are outside using fentanyl, we're getting naloxone kits as much as we can. But we have had, I was sitting in a room of about 12 of our participants, and we were talking about whenever they were doing fentanyl or had in the past done it. And I said, how many times have one of you used naloxone to help somebody? And they all put their hand up. And I said, and how many times have you called 911? And they said, none. Because what happens is the police come, and in all parts of Canada, there's the Good Samaritan law, where if the police show up, they shouldn't arrest anybody for anything, except if someone else has pending, they can wait. Like, people do get arrested whenever the police show up for things. So there's some movement nationally to try to have it be that police don't show up for 911 calls for overdoses for that very reason. So there's a whole bunch of people that are overdosing on a regular basis. They might be being revived by each other. And we have people that talk about at times before the program. One guy talked about how he died about 4 times a week, and his partner kept bringing him back, and she died 4 to 8 times a week. And now they only die once or twice a month now. I was like, oh my God, it's so sad. But anyway, so there's a whole bunch of uncaptured data because this is such a stigmatized area that people are so far below the radar.
Here's a question that somebody has asked. Is the Riverstone Recovery Center a charity? Is it a not-for-profit, or is it a business, or what actually is your structure?
Sure. So we're Riverstone's a not-for-profit. We're not a charity yet. So through SUAP, we've just stuck with being a not-for-profit. At some point, we would like to seek charitable status so people are able to make donations that they can get receipts for. But yeah, we're a not-for-profit.
So I want to ask you a bit about what message that you'd like the business community to take to the government, I guess. But I do want to tell you that just last week, the Chambers of Commerce from Fredericton, Moncton, and St. John wrote to our premier to ask that the province develop an urban mental health strategy for our communities. And it does seem as if perhaps the Victoria Health Centre could be a key piece of a plan of that nature for Fredericton. So I guess I would be interested in, what message you would want business people to share with government. And what is the ultimate message that you would like to share with the business community?
Oh boy, I wish I had everything written down in front of me I could keep talking. I'm so excited that you asked, Krista, and I appreciate the compassion in how I can just feel that, the wanting to share and wanting things to get better. And all of us here do too. So I would like you to know that we're here, and any concerns you have, we're open to hearing about it. And we'd like to be very problem and solution oriented, like problem receiving, solution oriented. So part of the key thing we have to do is we have to involve people who have the living experience in the design of things. So if there is success with moving forward, and the Victoria Health Centre for sure would be a perfect location. It can't just be the top down decides what happens, and then now we'll feed it down to the people that will be the recipients. And that, I think, is not only because we need to be inclusive, but it really is you design it better when you involve them. So part of the problem in places that are being created for people, like not everyone went to the warming center last year, and not everyone went to the cooling center in the summer. And people were scratching their head like, why not? But then when they talk to people, they realize the various barriers of why they couldn't. So it's starting with them, starting with the folks, getting them involved in providing what the best information would be to design that strategy. I know that the chief of police had involved the business community. I did go to that one because I am a co-owner of a business as well, my husband's business. And the residents downtown to talk about homelessness and trail safety, et cetera. And I said to him, I'm like, did you actually ask any homeless people for their input to your strategy? And he's like, no. And I said, well, come to Riverstone. And he actually came, and we had a bunch of people sit and talk with him. And he found it invaluable. He learned things that he had never thought of. So it's really important to involve the people themselves instead of a top-down approach, or it won't work. It just will not work. And you'll be really frustrated, and you'll think that was not worth it. So involving the community level that are delivering the care, super important as well. So it's really to make it as relevant as possible, because this would be a huge benefit. But unless the people, it's like nothing about us without us. You probably have heard at marches or what have you. That is a really important term. What I would love the business community to know is that 27 people, most of them living outside, applied for 5 cleaning positions at our clinic for minimum wage. They all want to work. The barriers that they identify are that having a criminal record, and very often from stealing in order to stay out of withdrawal. So it's this endless loop. We're developing a program to help people get their records expunged. So we're trying to work towards that ourselves. We need some fundraising for that because it costs money for each person. So we're trying to actively help people get rid of their criminal records for nuisance crimes. But that people do want to work, and we want to help work with you. So the Works Housing and Social Enterprise is developing this framework. I think that giving people the chance to actually like wear a Works shirt and like go and do something, that's going to do way more than their IO dose. So it's my theory is, or my motto is, believe in people, don't always believe them. So you don't necessarily have to get it, like there might be still some things that are challenging, but ultimately you still have to believe in people. So do believe in the folks that we have here, the people that are living outside. Sometimes they're too mentally unwell and too traumatized physically to be able to cope with the rigors of day-to-day life in a house. And we need special care homes for folks like that. But there aren't any because of their substance use. They're not designed for that. They literally, we have people that we've tried to get into special care homes that we've been told if they use any kind of substances, they won't be able to stay here. So until we switch and we make it a health issue, not a criminal issue, we're not really going to get ahead. So it's to reframe your thinking, make this into a health issue, reframe thinking that people don't want to do anything and recognize that they do, and that there are fledgling organizations like the Works trying to help develop that so that the businesses can we can work together and build some bridges and involve people who you want to design to help involve them in the design from the ground up, from all levels, so that we can actually make it relevant and make it effective. And I do thank you. And I thank you for I love the city. I'm an urbanite. I absolutely love cities. I want this to be the most beautiful, vibrant place. And it's going to be through involving everybody, not excluding people.
I'm going to, first of all, I want to say that as the Works gets going, if we have business members of our chamber that are interested in hiring your clients, we'll certainly put them in touch with you if they don't reach out directly. But I guess my last question, it's a complicated situation for the downtown, or not necessarily downtown businesses, but for our members who are the business community. The reason it's complicated is because they're compassionate, they're caring, they want to see people get the help they need, they want people to feel well, but at the same time, they're having challenges within their businesses in terms of things that are happening in the vicinity of their businesses. I guess my last question is, what do you feel that your responsibility or the clinic's responsibility is to those neighboring businesses who are our members and who are having a challenging time?
Yeah, it is a complicated question. I've been taking a lot of public heat for making homelessness come downtown. And I'm not going to wear that. What I'm going to wear is, there are people in our program that are around and they move along. And I'm sorry if that sounds abrupt, but it's not necessarily because people are downtown because of coming for medical treatment. The fact that people are downtown, I want to work with you, and I'm fine if you reach out to me directly here at the clinic. What we need to do is work together. We need to basically say to the province, you can't stop dumping social issues on businesses. Like, I'm not going to own that. You guys shouldn't have to own that. None of us should have to own that. And it's because of a stigmatizing belief that people who use drugs are lesser than, that they need to be incarcerated. So the idea that we're building a $32 million jail at a time when we really need desperately supported housing is offensive. So I would encourage you to use your anger to turn it upstream. I would encourage you, though, to let us know specific things you're having. We'll do what we can if we know it's our participants to work with them directly with case management, for sure. So I'm not saying we won't do anything. I just, that the bigger idea that somehow Riverstone has brought homelessness downtown is just it's false. So we can't fix that. We can't disappear people. But again, if you have specific people that you want to bring to our attention, if they're in our program, we actually have that opportunity. We have that relationship. We can work with that. What we started to do with the works is we have part of our piecework is we have people that go over to 554 and they clean up the area twice a week. Happy to do that. They're being paid for it though. So I guess it depends on, we're a not-for-profit. We don't have a giant amount of funding that we can say we're going to clean up the whole downtown. But what we would love to do, some of our participants actually want to go out and they actually want to do scoping over areas to pick up all the needles that other people have left. They actually would like to do that. So we'd love to have the city become partners with the works and involved with that. We could actually employ our peeps to help take care of a lot of those problems that you're having. Now, if it's someone who's freaking out because they have schizophrenia, they haven't lived anywhere for 5 years and they're not in our program, I just think we need to demand that the government does better and create special care homes for people with that depth of mental health issue. There's like a handful of people that are probably causing the most grief, and they have profound mental health issues. They may be using substances because, my God, if you were living outside for 5 years, you probably would too. And they are not being met. They can't get treatment at mental health because mental health, they can't go down and make an appointment and show up on time and their case gets closed. It's excruciatingly frustrating. And if I sound offensive, it's just because, believe me, my head is very hard and I bang it all the time on things. So my promise to you is we want to be engaged partners through employing people to actually help. But again, we can't just say, hey, all of you volunteer and do all this stuff because you've wrecked the city. And not that you're saying that, but I mean, we just have to be careful how we identify people's labor and that we want to support them because they'll actually get self-esteem and then they'll become more likely to actually be successful working. I would love to do that. We want to build that up. That's why the works exists. And we want to make that happen more. Individual people, if you want to let us know who they are, if we know who they are and we can help, we'll case manage, no problem. But I cannot say enough that we can't accept as businesses, as healthcare not-for-profits, that we're carrying the brunt of what needs to be a much more leadership-led approach to changing the dialogue and making way more resources available because, what is it, $800 million surplus? I mean, it's phenomenal that it's being left up to you to feel guilty about moving someone along out of your front stoop because they had to sleep there. Like, it's just, you shouldn't have to do that. So I don't know if that's a complicated answer, Krista. I'm sorry again if I sounded defensive. I just am, it's so frustrating all the time. It's frustrating for us too. And we want to be partners that help and be involved. So let's keep the dialogue going. That's probably the bottom line. Please keep it going.
I definitely want to say thank you so much, Dr. Davidson, for your time today, for sharing a lot of information. And a lot of this is new information and very eye-opening for our members who have joined us today. I want to thank everybody who attended today and helped to educate themselves through Sarah's presentation as to the Riverstone Recovery Center's program. And I want to remind everyone that we did record this session and we will be sharing it on our social media. And I would encourage all of you to take the time to share it as well so that others can learn the important information that we learned today. So again, thank you very much, Dr. Davidson, and we really appreciate your time today, and we will keep the dialogue open and keep talking about this. So thanks very much.
Thanks very much, everybody. Appreciate it.